Many contraindications of beta blocker are the indications of this calcium channel blocker. These drugs in cardiology I have arranged in the way so that the contraindication of one group become the indication of another group. Why it come into existence? The answer is that to overcome some of the contraindications of beta blocker. Now, before going to the details of calcium channel blocker, I just want to tell you a very simple thing, and that is, this is a smooth muscle. Entry of calcium ion is responsible for contraction of the smooth muscle, actin myosin coupling. That actin myosin coupling depend upon this calcium ion, and that's why this calcium ion is very essential for the contraction of the smooth muscle. All of you know this is the vessel. The vessel is made up of the smooth muscles, a circular smooth muscle and a longitudinal smooth muscles. The smooth muscles are from this part. They are like here. This is circular smooth muscles and these are longitudinal smooth muscle. When they contract, the vessel will contract by all the sides. Are you getting my point? Yes. And when the vessel will relax, when it will relax? When you block the entry of the calcium ion. Because the contraction of the smooth muscle depend upon calcium ion. Entry of the calcium is essential for actin myosin coupling. And actin myosin coupling is the primary event responsible for a smooth muscle contraction. It is a very basic thing I am telling you. The actin myosin chain is there. These are the two proteins. They couple with each other and they contract. The protein actually contracts. Are you getting my point? Yes. And that requires calcium ion. And that's why calcium ion is essential for the smooth muscle contraction. If you can block it, the vessel will dilate. Vessel will dilate. Now, to be very clear with you, these drugs are arteriolar dilators. These are arteriolar dilators. They dilate the arteries. Are you getting my point? Are you getting my point? They are arteriolar dilators. They dilate the arteries. The effect on vein is not much prominent. They are not venodilators. There are the drugs, those are venodilators, and those are nitrates, isosorbate dinitrate. Dominant effect on the vein. This is dominant effect on the arteries. Everyone is with me? Everyone is with me? Second important thing, you got the concept? Why we are going to block? And these are known as L-type. Channels, calcium channels are of three types. You just now remember L-type, T-type are there. T-type are there in the CNS. Peripheral vessels are having L-type. This is not a lecture to go in detail of how the calcium channels are. You now remember very simple thing that vessel contraction depend upon this calcium ion. And it will bring about arteriolar dilation. Because we are going to block the entry of calcium ion. These drugs are going to block the calcium ion. Now, point is very important. The calcium channel blockers are principally divided into two parts. The cardio-selective and non-cardio-selective. Yes. Non-cardio-selective are all dihydropyridines. All dihydropyridine, the drug ending with pins. The name of the drug ending with pins. nifedipine, felodipine, nifedipine, felodipine, nitradipine. All pins ending with the pin are all dihydropyridines. And these are the drugs having no effect on the heart. My sentence is very serious. No effect on heart at therapeutic dose. No effect on the heart with therapeutic dose. They are only vasodilators. They are only vasodilators. This is a very important point. They are only vasodilators. Are you with me, my dear students? Everyone is with me? Everyone is with me? Now, these drugs, and these are many drugs, that is also important. These are many drugs. Getting my point? Now, these cardio-selective drugs are few, only two. That is verapamil and diltiazem. And these drugs are having three important properties. Now this is very important. They have negative chronotrophic action. They have negative inotrophic action. They have negative dromotrophic action. I will explain one by one. Negative chronotrophic action is related to reduction in heart rate. Negative chronotrophic action means reduction in heart rate. Negative inotrophic action means reduction in force of contraction of the heart. Getting my point? And negative dromotrophic action means reduction in conduction of impulse. Through bundle of His. Actually, SA node to AV node to bundle of His is the conduction pathway. That pathway is suppressed because the conduction of the impulse also depend upon calcium ion. Conduction of the impulse through heart itself, through Purkinje's fiber, bundle of His also depend upon calcium ion. Contraction of the heart itself depend upon calcium ion. Depolarization of SA node also depend upon calcium ion. I am very much serious about my every word. When the calcium ion you block from entry into SA node, it affects the heart rate because firing of SA node reduces. This is one point. When you are going to affect the entry of calcium in the myocardium, it will give you negative inotrophic action. It reduces the force of contraction of the heart. And when the calcium entry in the now conduction in that heart, that is bundle of His right and left branches and Purkinje's fiber reduces. It reduces the conduction of impulse. That is known as negative dromotrophic action. Negative chronotrophic action means effect on the SA node, reduces the heart rate. Firing of SA node reduces. Are you with me, my dear student? The second is inotrophic action. It means force of contraction, reduction in the myocardium. Calcium entry in myocardium reduces, gives you negative inotrophic action. Are you with me? And the entry in the conduction system of calcium reduces. It will reduces the firing. Are you getting conduction through the bundle of His right and left branches and Purkinje's fiber? But do remember, my dear student, the chronotrophic, negative inotrophic and negative dromotrophic action is only applicable to verapamil and diltiazem. It is not at all applicable to these drugs. Why I am telling you all these things? The problem is that these drugs, because of this property, cannot be combined with beta blockers. Because beta blocker also reduces the heart rate. Beta blocker also reduces the force of contraction. Beta blocker also blocks the AV node. And that's why this drug, if combined with beta blockers, cardiac asystole may take place. Sudden blocking of the heart, pumping of the heart may stop. That is what we call cardiac asystole may take place. And that's why these are strictly contraindicated to be combined with beta blocker, because they are having all these properties. Now my sentence is very important. And these drugs can be safely combined with beta blockers, because they are only vasodilators. Penes, dihydropyridine is a group. The dihydropyridines are very easily combined with beta blockers, because at therapeutic doses they don't affect the heart rate, they don't affect the force of contraction, they don't have any blocking activity for AV node. Are you getting my point? Everyone is getting my point? And that's why you will get the combination of amlodipine with atenolol. Amlodipine with atenolol is famous, stamlo beta. Khadak. Stamlo beta. We write it, we prescribe it from the OPD. Stamlo beta can be combined. Are you getting my point? Are you getting my point? Hope so you got the point. Everyone got my point. Should I proceed for the lecture? This is the introduction. Once you understand this difference, you will understand each and every drug properly. Are you getting my point? Now I should tell you about the drugs. Now this deltazim is little bit funny man. Deltazim is little bit funny man, because it is towards verapamil, but it is not completely on the verapamil side. If you draw the line, these are suppose dihydropyridines and this is verapamil. These are dihydropyridines. You draw a line, then diltiazem is here. It is close to verapamil, but it is not exactly as verapamil. It is having some properties of dihydropyridines also. And that's why diltiazem can be used as an antihypertensive drug. It is not regularly used as antihypertensive drug, that is very clear. But it can be used. In some countries, it is recognized as antihypertensive. Why? Because it is not completely towards verapamil. It is partially towards verapamil. It is not exactly as verapamil, but is close to verapamil. It should not be combined with beta blockers, that is known. But itself can be used as antihypertensive drug, because it is not exact as that of verapamil. It is very close to, not very close, but close to verapamil, but not much away even from dihydropyridine. I mean to say that it can be used as a vasodilator, it can be used as a drug having negative inotropic actions, negative chronotropic action, negative dromotropic action. Some of these properties and some of these properties are applicable to diltiazem. But classification wise, diltiazem is cardioselective. Classification wise, diltiazem is cardioselective. Yes. Then he is thinking very seriously. Dr. Joshi, these cannot be used as antihypertensives regularly. In India, at least we don't use them as antihypertensives. What is the role of these drugs, sir? These are the drugs, those are used to control the heart rate. Those are generally used to control heart rate in a condition known as PSVT. Paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. Paroxysmal madna yenara. Intermittently coming. Supraventricular tachycardia. SVT. SVT, yesterday I told you. The distance between the two R wave reduces and the heart rate is above 150. Is likely to be a case of SVT. And it is happening intermittently. Means what happens? Sometime normal rhythm is there, sometime SVT comes. Sometime normal rhythm is there, sometime SVT comes. Actually, it happens in young age, happens suddenly, and it is always, the point is important, it is always benign. माणूस मरत नाही एसपीटीने, पीएसपीटीने मरत नाही कधीच. Yes, but it is troublesome because it may happen any time. You are driving the car and PSVT will be there. Like this. And after say 1 minute, patient is okay. That is a major point of PSVT. It may come any time. Typically seen in the young age. It is generally due to the extra bundles. You know the bundle of his right and left branches. Extra bundles are there. And that is the reason why PSVT develops. Yes. Yes. You have to go for ablation therapy. Ablation, burning of that extra bundle is known as ablation therapy. Yes. Electrophysiologists are there. Cardio-electrophysiologist is a super specialty of cardiology. AIMS, in Delhi AIMS the specialty is there. Electrophysiologist. They are going to do this surgery. They go for ablation. That is the permanent cure of this PSVT. But for the treatment purpose, we use verapamil is a drug of choice. PSVT only, verapamil. To control the rate in SVT, the choice is beta blocker. Yesterday I told you, AHA indicates sotalol. India in sotalol is not available. Then we recommend ismolol. If ismolol is not present, you are having the option to go with verapamil. Verapamil can also be used for the SVT, pure SVT, supraventricular tachycardia. You can use it. Isoptin is a famous trade name. 5 mg per ml is a preparation available in the market. PSVT, paroxysmal supraventricular tachycardia as well as regular SVT. Where you can use, indication is of ismolol, but you can use verapamil also. I am giving you all the idea about these drugs. I think that I should start with the lecture because already I spent 25 minutes telling you the basics. But basics are very important, my dear student, always remember. So if someone is telling you basics are not important, come directly to the application, he is the fullest person in the world. सगळ्यात मूर्ख माणूस तो असतो तो जो असं सांगतो की बेसिक्स काय फार महत्त्वाचे नाही आहेत, तू ॲप्लिकेशनचा पार्टचा अभ्यास कर. बिंडोक माणूस आहे, बिंडोक, महाबिंडोक, मोठा महाबिंडोक माणूस आहे. विदाऊट बेसिक्स नेवर. आय विल टेल यू, मला तुम्हाला सांगायला आवडेल की जगातलं एकही संशोधन विदाऊट बेसिक झालेलं नाही आहे. आणि तुम्ही हसाल इतकं ते बेसिक असतं, म्हणजे आपल्याला का नाही सुचलं. एव्हरी इन्व्हेन्शन is always around the basics, always and always. Let us see. Shall I start now? Two important group of the drugs are there in the CCBs. Cardioselective, the verapamil and deltazam having the prominent action on the heart, and non-cardioselective nifedipine-like drugs having negligible action on the heart but a prominent action on the peripheral vessels, especially arteriolar dilator. These are chemically diverse but pharmacologically similar. They block the entry of calcium and the smooth muscles of the heart and the blood vessels. Pharmacological actions. Smooth muscle relaxation, especially of the blood vessel. Non-cardioselective drugs like nifedipine is having this action. Am I right? Nifedipine is an example I have taken. Negative chronotrophic action. That is heart rate reduces. Inotrophic action, force of contraction reduces, already told you. And negative dromotrophic action, conduction of the impulse through the nerves, that is the system. Conduction system कुठली आहे तुझी? SA node to AV node to bundle of his right and left branches. This is also conduction. That conduction also reduces by verapamil. But this is due to cardioselective verapamil. Already told you about it. The inward movement of the calcium is responsible for depolarization of the cardiac muscles. Calcium channel blockers cause relaxation of the smooth muscle by decreasing the intracellular availability of calcium, because activation of calcium, activation of actin-myosin chain, which is a principal event for the contraction of the any muscle, Actin myosin chain is concerned with contraction of the muscle, initiates with calcium. And the calcium is essential for that process. If you block the calcium, the actin myosin chain will not work. Actin myosin chain will not work. And when actin myosin chain is not going to work, the muscle will remain relaxed. And that is the basic idea behind the use of calcium channel blockers. Yesterday I talked to you, my dear students, that in bronchus the same thing is there. Because bronchus is also made up of smooth muscles. And that's why in one way these are helping for bronchodilation. And that is the reason, my dear student, the same smooth muscle is there in the bronchus. Dilation of the bronchus also depends upon these calcium ions. And that's why when you are using these calcium channel blockers to control the blood pressure of a patient who is already an asthmatic patient, you will get little more benefit. They are not bronchus specific, and that's why these drugs cannot be used as bronchodilators, because they are not having some, what I mean to say, the receptors are not much there on the smooth muscles. Therefore, you cannot use them as a bronchodilator, but they will little contribute to bronchodilation. At least they will not bring about bronchoconstriction like beta blockers. Beta blockers are dangerous for that. Are you getting my point? And this is why principal indication of these drugs is COPD, asthma, all type of COPD, chronic obstructive pulmonary diseases, bronchitis, bronchiectasis, asthma, patients of tuberculosis. If they are hypertensive, this is the best choice for them. See, you just remember the choices in the mind. That is very important. Kunal काय द्यायचं? Am I right? Yes. But go through basics. Why? What is the purpose of our lectures? Why? The student should understand that why I have selected this drug. The contraction of the cardiac muscle fiber depend upon calcium. Again, the actin myosin chain require calcium. Calcium channel blockers are responsible for blocking of the calcium, and hence the drug have negative chronotrophic action on the heart. Force of contraction of heart also reduces. The conduction through the nerves depend upon calcium. Verapamil is most active in this regard. Nifedipine has no such action. And diltiazem is intermittent. Diltiazem is intermittent. That's why I told you about, if you make a straight line in between the non-cardioselective and cardioselective, the diltiazem is not in between but is inclined towards verapamil. But it's not very close to verapamil. That is what I told. And that's why the negative inotropic action of the diltiazem is intermittent. This is what I just made an idea. Very simple. This is smooth muscle contraction. The entry of calcium is essential for it. And if you can block the calcium ion by using the calcium channel blockers, the calcium will not enter and the muscle will remain relaxed. And if the muscle is relaxed, the vessel will be dilated. And that is the whole idea of using calcium channel blocker. L type, you keep it in mind. L type. Calcium and blocked by CCBs, no contraction of the smooth muscle will take place. The same thing happens in the nerve. This is very simple. These are the calcium ions. The entry of the calcium ion is responsible for opening of the vesicle. This is the vesicle is going to open, and these are the neurotransmitter release. And this is how the conduction will happen to the next thing. Are you getting? That also depend upon entry of the calcium. म्हणजे नवीन सिरीज जी येते ना, याचे सगळे ॲनिमेशन्स आहेत. कसं जातं, ओपन कसं होतं, ड्रग ब्लॉक कसं करतो, सगळं ॲनिमेशन केलेत मी त्याचं. You will get that wonderful lecture series. Are you getting my point? Are you getting my point? Yes. Verapamil. Dilate the arterioles and some alpha adrenergic blocking action. Alpha adrenergic blocking action is? Alpha action is vasoconstriction. The blocking of alpha will bring about vasodilation. But that is not the prominent action of verapamil. That is not the prominent action of verapamil. What is the prominent action of verapamil? Negative inotrophic, negative chronotrophic, negative thrombotrophic. That is the prominent action. It is having some alpha adrenergic blocking action. It decreases the TPR, but BP is only moderately lowered. And that's why it should not be used as an antihypertensive drug. It should not be used as antihypertensive drug. It has selective cardiodepressant action, and that is the reason to use verapamil. It is having selective cardiodepressant action, means it is a cardioselective calcium channel blocker. Repeatedly telling you the same thing. Gradually decreases, heart rate gradually decreases. AV conduction is slowed, but cardiac output is maintained by reflex sympathetic stimulation. What is this point? Whenever you are trying to reduce the blood pressure, body will oppose it. Are you getting my point? Yes. And that's why sudden reduction in the blood pressure is always dangerous, because body will put cardiotonic action. Are you getting my point? Yes. That is known as reflex sympathetic stimulation. That is known as reflex. Why? BP is reducing. Body by reflex gives you tachycardia, gives you increase in the force of contraction. Are you getting it? Now what I am trying to say, when the heart rate is reducing, body reflexly will increase the heart rate, bring about the response by the body, and that's why if you see, actually the cardiac output is maintained by reflex sympathetic stimulation. Due to the coronary vasodilation, coronary blood flow is also increased. Why? Coronaries are arteries. Coronaries are arteries, and that's why there is dilation of the coronaries by verapamil. Are you getting it? Yes. General. Nausea, constipation, bradycardia. Nausea, constipation, bradycardia. It is related. Negative, chronotrophic action. Reduces the heart. Nausea is okay. Nausea is with all any of the drug. Why constipation is there? Smooth muscle relaxant effect. Peristaltic is a movement. Smooth muscles are there. Are you getting my point? It is having smooth muscle relaxant effect. And that's why constipation is related to the principal action of the drug. Getting my point? Yes. While flushing of ankle edema may happen, this is again a very important point. Few patients on CCBs show you ankle edema. Why? The answer is very simple. Suppose this is the tissue, my dear students, and these are the vessels coming. This is the capillary network, and this is the venule. This is arteriole, this is venule. What the drugs are? What the drugs are? The drugs are arteriolar dilators. When the arteriole is going to dilate, flow of the blood to the tissue will increase. Am I right? These are the capillary network. They will ooze out. They will ooze out. And there is not much dilation of the vessels. Venule is not going to dilate. That's why dilation of the arteries will put more blood here, more oozing will take place, and drainage is not so good because there is no dilation of veins. And that's why this remains the possibility that the plasma may accumulate here. And this will end up into edema, ankle edema. Not happen in every patient, but it is a possibility. And this is more with pins. This is more with pins. Amlodipine is famous for it. Not in all patients, but in some patients. Ankle edema is a side effect of calcium channel blocker, especially pins. We are talking about verapamil, I know, but still it is applicable for pins. Should I proceed? Everyone is happy with the words? Why ankle edema takes place? This is the mechanism of ankle edema. Hypotension may take place because it is all negative. It aggravates the conduction defects and is contraindicated with the HB. Verapamil should not be used with any patient of heart block. And that's why you should understand the heart block. HB you must know, first degree, second degree, third degree HB. You must understand that HB. Everyone is with me? Everyone is with me? Patient anions may precipitate CCF. Congestive cardiac failure may be precipitated because it is negative chronotrophic, negative inotrophic, negative chronotrophic action. HB patient, you should not use verapamil. Now I should tell you very important thing. In a patient of heart block, you can reliably use pins. There is no problem for non-cardioselective drugs to be used in the patients of heart block. First degree heart block, second degree heart block, you can use pins. Dihydropyridines is the group that can be safely used in HB, but not the verapamil, not the deltazem, not deltazem, not verapamil. Are you getting my point? Yes. Interactions. It should not be used with beta blockers because antidepressant action will take place and cardiac systole may happen. That is what I already told you. Verapamil or any of the cardioselective calcium channel blocker should not be combined with beta blockers. But non-cardioselective calcium channel blockers are always combined with beta blockers. Non-cardioselective you can. Amlodipine plus atenolol is available in the market. But not the cardioselective. Verapamil is cardioselective. It increases the plasma digoxin level and decreases the excretion. Toxicity of digoxin may take place. And the second important thing about digoxin is that digoxin reduces the heart rate. Verapamil also reduces the heart rate. And that's why digoxin should not be used with verapamil, or verapamil should not be used in the patient who is on digoxin. This is another important thing. It increases the digoxin levels by decreasing its excretion. Verapamil interferes with the excretion of digoxin, and that's why it should not be combined with digoxin. This is one reason. Second reason I told you. Digoxin also reduces the heart rate. Verapamil also reduces the heart rate. Two drugs reducing the heart rate should not be combined because they may give you cardiac systole. Getting my point? Yes. It should not be used concurrently with the other cardiac depressants like quinidine. I told you the same sentence. Two drugs, both are reducing the heart rate, should not be combined. Isopten, very famous trade name. 5 milligram per 2 ml is the ampule available for all emergency purposes. PSVT is emergency. PSVT is a prime indication of that drug. Paroxysmal supraventricular tachycardia. Already I told you there is less distance between the R waves. This is all are same. Huh? Now what happens? Again the normal heart rate starts. And after some time again the complexes are coming close to each other. These are close to each other. These are normal. And again they are coming close to each other. And this is they are repeating. And that's why I am using the word paroxysmal. Madhun enar. In between normal is there. Am I right? If this thing is happening, then verapamil is a drug of choice. Now, in these cases, this should not develop recurrently. And that's why these patients are kept on 40 milligram TDS of isopten. 40 milligram TDS of isopten. Are you getting my point? Isopten means verapamil. 40 milligram TDS. TDS, 3 times a day. Are you getting my point? Yes. Till you go for that ablation therapy. Or otherwise, lifetime. Because extra bundle is there. PSVT is most of the time extra bundle. You have to burn it. That is known as ablation therapy. Electrophysiologist, I told you. Yes. I know one who is studying in, at this time, he is studying in KIMS. डॉक्टर देशपांडेंचा मुलगा आहे, त्याचं नाव नाही मला सांगता येणार. भोसले श्रीरामपूर नावाचं गाव आहे इथे, तिथे गायनाकोलॉजिस्ट आहेत देशपांडे म्हणून. माझा डायरेक्ट परिचय नाही आहे, पण ते टाकत असतात त्यांच्या मुलाविषयी काही काही. ग्रुप आहे ग्रुपमध्ये, तेव्हा मला माहिती पडलं. टॅबलेट Absorptin 40 to 80 milligram, 240 milligram SR. Injection Absorptin 5 milligram per 2 ml, 40 to 120 milligram TDS. Most common dose is 40 milligram TDS. If it is PSVD is rare. Yes. Just I was teaching like this, and one student after the completing lecture and came and talked to me. Sir, I am patient. मला होतं असं. सो गुड पेशंट. कांक्रिया नाव द्या पोराचं. खूप जुनी गोष्ट आहे ही, 10 वर्षाला असेल. त्याने मला येऊन सांगितलं की सर मी याचा पेशंट आहे. आणि काय गंमत घडावी, 3-1 दिवसांमध्ये त्याला त्रास झाला. तर काय रोज होतो असं नाही, केव्हाही होतो. एनी टाईम 15 दिवसातून एकदा होईल, एका वर्षातून एकदा होईल, माहीत नाही. आणि ही वॉज वर्किंग इन अ हॉस्पिटल. तर त्या पोरगं इतकं चांगलं, त्यांनी साला ECG करून आणला पोरांना दाखवायला. अरे असं दिसतं. सो गुड बॉय. ते घडलं म्हणजे त्या वेळेत नेमकं घडलं. ते घडायलाच असं नसतं. इट मे हॅपन once in 6 months, once in a year, twice in month, twice in 1 day. There is no fixed, and that's why the words are paroxysmal. That's why the words are paroxysmal. Any time it may come. Getting my point? Yes.